Maybe before we go to the last speaker, since the first section is on tricuspid, that we take 5 minutes for discussion and then we'll finish with Steve. I guess open up the panel. Any comments, questions on any of the topics that we've discussed thus far? Greg, can I ask you a question? So did we miss our window then? I mean, so is there going to be a randomized trial in tricuspid therapy against that doesn't involve an approved device? And if so, how do you control that?
So we're trying, so the answer is no. I don't think you'll ever see that. I think that window is gone. And so the real question is now that people are asking me, well, do I think these transcatheter devices are effective? So if you look at so far what we've seen for the placebo effect, it seems like the effect in KCCQ is somewhere between about 8 and 10 points for the placebo effect. We're seeing in those two randomized trials somewhere between an incremental between group change of 13 to 18 points. So I think there's probably some benefit in terms of quality of life. That's the best I can come up with now. Once we've looked at 200 other blinded trials and broken it down into pharma versus device and HFrEF versus HFpEF, et cetera, we'll try to get better estimates. But I think that, you know, the cat is out of the bag. I mean, FDA is not going to start requiring sham-controlled trials. But I do think that if we ever do compare TEER to TMVR, those should be blinded trials. The patient does not need to know whether they've gotten a valve or whether they've gotten T-TEER. They can be blinded, the patients can be blinded, and all healthcare assessors out of the cath lab can be blinded.
Can I ask a question to the rest of the panel and to Greg as well? Blinding in the era of EMR. I see a patient for follow-up at TriClip. I get a call. I saw the echo report. It says that there's, moderate leak. The next day I get a call before I've looked at the echo. How do we do blinding in the era? And I know there are ways, but I'd like to have this discussion. But it poses significant challenges in the era of EMRs, I think.
Yeah, so sometimes, in chest x-rays and in echoes, you can see these devices, obviously, and depending on some devices, other times you can't, and other times you do get those kinds of reports. So you have to have a separate group of docs who did, and research people who did the procedure in the cath lab, and then who follow up the patient. And those types of reports need to go to the unblinded doctors.
And not to the patient.
And not to the patient, and not to the another physician following the patient after the cath lab. Obviously, there's occasional times you're going to have to unblind. Yeah. But if you can keep 80 to 90% of the patients blinded, at least you're doing the best job you absolutely can. You'll never make it perfect, but I think you can keep most people blinded and most assessors blinded.
Greg, would you think that these blinding will be less important on device comparison compared to device versus medical therapy? Unless if you're Edwards employee that is getting, Abbott clip. I don't think they're going to report something with some, prejudice on it.
No, because, the problem is, why do we see these relationships in the unblinded trials between the reduction in TR, right? Evoque's going to have less TR than T-TEER. And you say, oh, well, the greater the TR reduction, the better the quality of life. Well, why is that? Because the doc says, guess what? You're going to be feeling great. You have no more TR. Okay? In an unblinded trial, that's the problem because of those correlations and those biases in ascertainment. So particularly, I think, actually, when you're taking a higher risk device and a lower risk device, then you've really got to have a very fair assessment as to is there greater effectiveness. And you can't tell the patient, oh, you got the valve, so you've got no TR, so you should be feeling better, and keep walking. You can walk farther than that when you do your 6-minute walk,
It could be the physician bias
that
transmits to the patient.
Absolutely. That's what we mean by ascertainment bias. There's physician bias.
Renika, can I ask you a question? So you and Steve are the scarcest resource in this room, we're trying to hire an interventional echocardiographer at Columbia. It's very challenging. It's the scarcest resource. Yeah. How, you said it's trainable, it's reproducible. We don't even have enough imagers. We have to have it limited. How are we going to actually make these technologies, broader, more broadly available? What are the roles for AI, automation, or do we just have to train more people and pay them adequately? Because just throw that out there as well. There is not adequate reimbursement for the interventional imager, whether it's an RVU model or a fee-for-service model. So what do we have to do? What do societies have to do? How do we move this forward? I know it's a big question, but a loaded question, but I want to ask you.
It's a great question. So what I'm learning is that we have plenty of interventional cardiologists, and we have a lot of surgeons, but we don't have enough heart failure docs and imaging docs. The first thing is that I do think that it's been great in the last 5 years that we have introduced more advanced imaging fellowships. If anyone wants to come to Wisconsin, we have a spot in 2026. But that's not going to be enough. And I think the second thing is that we have to really address what I think is the biggest problem, which is reimbursement. I get paid nothing for doing a 3-hour TriClip, which is why I'm very, very motivated to do it quickly and efficiently. I have a hospital system that supports it. I've got great interventional and surgical partners in Milwaukee that support me in doing it. But that is really, to me, the biggest thing. And when I talk to cardiology fellows, why would anyone want to go in interventional imaging and spend a whole day doing, 2 TriClips and an Evoke and get, 10 RVUs as opposed to what we can do otherwise. I do think AI is going to be a great factor in it. You saw Lucy, right? And Gilbert saying kind of the rate limiting step is Lucy's ability to get an NPR together. And I do think that's going to help us. But I hope that we have a heart valve team support for IE compensation. I don't know, Steve, what do you think?
Yeah, it's a critical question. I think they're related. I mean, thinking first about the technologies, the TTVR, right? We put in things that are circles. They started off as, CardiAQ was conceived as a TAVR device, didn't really work in the mitral position, lateral to the tricuspid position. It's positionally agnostic. It ignores the conduction system. I mean, we could easily, if there were a device that the imager could say, look, rotate. We rotate everything in the mitral space, all the tiers, we're rotating, we're positioning. We don't do any of that in the TTVR or frankly in the current version of the TMVR devices. So I think imagers can be a lot of help in terms of how we implant these things that actually respect the anatomy that needs to be respected. And I think payment reform will completely change how we deliver individuals who are trained for these technologies. So this is coming up now for the NCD, for all the tricuspid stuff. If we are successful in having the imager branded as a co-operator, not just somebody doing a diagnostic test, if you're a co-operator and you get paid as such, there's already a huge amount of academic interest and clinical interest, and imagers want the challenge, but they can't do it because they can't get paid. So I think payment reform is everything.
I think it's critical, and I think we have to push the societies to advocate, and we as groups have to advocate because that's, you're fortunate, we're fortunate that our institution supports this. Steve's fortunate probably because the institution supports, but there are a lot of in communities where it's not supported by the hospital, and that's going to really, it's going to affect the quality of the people that are doing it. It's going to affect their ability to spend time to do it, and these are critical sort of things that we have to figure out how to address.
And Steve's going to talk about LAO next. That is the fastest growing structural procedure in the country right now. And that requires echo imaging. And I think a lot of ICE and, the movement towards a minimalist approach is not necessarily driven by quality, but maybe driven by the fact that it's hard to get one of us in there. The last thing I want to do after 3 Evokes is go do 4 Watchmen.
Yeah,
So.
exactly. So we have a little bit of time for discussion. So I've been talking. So any comments from the panel? Any questions or comments regarding any of the talks, but especially with what Steve just sort of discussed?
I have a question, and Renu mentioned that this is the fastest growing procedure in interventional, in structural intervention. It's a 2B indication.
I know.
I'm just trying to understand, why is that?
It's a lot of patients. And nobody wants to take anticoagulation, and they're probably not really following the true indication. There isn't a concept of non-inferiority out there. Anticoagulation is dangerous. We can get you off that dangerous thing. We'll give you a device that changes everything. And they often, in registry data, they don't go on 90 days of anticoagulation. And I think the whole notion of non-inferiority is really not the way they're discussed.
There's also the question of finances for some people. They don't want to take warfarin. DOAC costs money, and get a procedure. And we sort of can't dismiss that. That does play a role for some of these patients. The monthly expense of paying for a DOAC is not trivial for some people. Question, you said 25% nationally are being done by ICE alone?
Around that, it's, yeah, I mean, it was 15 to 25%, it's in that range.
So that scares me. And I'll just say why. I mean, we've done ICE procedures, but you're saying the acceptable peri-device leak is 3 millimeters. I know 4D ICE is getting better. I know some of the color is getting better. At least when I've done MitraClips with ICE, the color, I have a hard time with it. And one, are there technical skills, and is the imaging adequate? Because it's not just putting a plug. If you put a plug and you don't get a good result, and you end up with, you probably put the patient in a worse position. Are you, or people at this panel, are they feel comfortable, like, in terms of how this is being done, and can it adequately be assessed with ICE, the result?
You know, I would say that of the 15 to 25% that are ICE only, I think where it's been really successful is people that move towards it as part of a minimalist strategy, and that's all they do. So dabbling in ICE because you can't find an interventional imager is not the right way to do it. We have a lot of operators who do left atrial appendage occlusion, and we have 2 that have just made ICE their practice. And they've got great results. So 3D ICE, the same 3D ICE that we use for tricuspid, also works very, very well for left atrial appendage. It's one hole, so it's actually a little bit easier. NPR as well works very, very well in the 3D space on ICE. Transeptal, I think, is no problem. The EP guys have been doing it for years. And then with color as well and seeing gaps, I feel very, very comfortable with people that have made it part of their strategy, have gone and learned, but it's the dabblers that I worry
So
about.
do you think that should be the routine then, if you're comfortable? Do you think it's just it's a better
I think
approach?
if you make it a part of your practice and you do it all the time and you go through the training, what we have is we have interventional cardiologists or EPs who are partnered with structural sonographers. I actually send them for training also to sites that do a high volume of them, and then we come back. But I don't think it's a replacement for an interventional imager. It has to be done as part of conscious sedation, same-day discharge, minimalist, and it has to be done with an IC who understands echo imaging. Not all of you are the same. Many of you here are experts in echo imaging, right? But that's not the case throughout. That's my opinion. I don't know, Steve, what you think. You guys have EPs also that do it
So
with ICE.
I think, so Sheila, it sort of does relate to who's doing the procedure. So our center, it's done almost exclusively by electrophysiologists. They spend a ton of time, they have the AF patients, they spend a ton of time in the LA doing ablations, they're very comfortable with ICE and transeptals, and largely out of frustration of not being able to schedule us to be there, they just evolved into an ICE-only strategy. Now the question is, it's not really the modality that's the problem, is are they dedicating their time, interest, and capacity and competence to find tiny leaks? And I think that's a relatively new focus, is that even the 3 millimeters is a problem. So I think they will have to look for it.
Got it.
I think there's also a part of doing a CT pre-procedure and making sure that it's the right patient for ICE. And that really needs to focus in the conversation. Ooh, looks like we're ready.